So next we'll see about hemochromatosis. Here again, that is a metabolic disorder which is an autosomal recessive inheritance, and this is going to be caused due to iron overload. So any kind of iron overload, suppose the patient is having repeated blood transfusions or due to some inherited cause like hemochromatosis. So during repeated blood transfusion, iron overload is going to be called as hemosiderosis. While if it is a hereditary condition of iron overload, then it is going to be called as hemochromatosis. So hemochromatosis is going to be caused due to mutations in various genes like HFE gene, which is going to be present on chromosome 6p, then HAM gene, which is going to encode hepcidin. Hepcidin is involved in iron metabolism, iron absorption, right? Then hemojuvelin, HJV is hemojuvelin, and then transferrin receptor 2. So transferrin receptor 2. So all of these 4 mutations can result in hemochromatosis. Here again, there is going to be an increased risk of hepatocellular carcinoma. So the classical triad of hemochromatosis is it involves the liver, pancreas, and skin. So in the liver, it is going to cause micronodular cirrhosis because of the deposition of the iron. Then in pancreas, it is going to deposit in the islets of Langerhans. So the beta cells will be destroyed, and that will result in diabetes mellitus. And in the skin, it is going to cause deposition of hemosiderin. Apart from that, there is also going to be melanin pigmentation. So melanin more than hemosiderin is responsible for a slate gray appearance of the skin, which is called as bronze diabetes. Since diabetes is also associated, it is going to be called as bronze diabetes. Okay, one thing I forgot to mention, that the type of cirrhosis associated in Wilson's disease is going to be macronodular. So macronodular cirrhosis we see in very few specific conditions. So V and W you can think. So viral hepatitis, V and W. So both of this is going to have macronodular cirrhosis. Okay. While most of the other conditions, it is going to be micronodular cirrhosis. And microscopically, if you see again in the liver, there is going to be some coarse golden yellow brownish pigment, which is called as hemosiderin, and this pigment is going to be kind of refractile. So this kind of deposition in the liver, we will have to think about hemochromatosis, and this can be confirmed in the presence of a Pearl's Prussian blue reaction. So iron anywhere, Pearl's Prussian blue reaction will be positive and it will give a blue colored staining. Okay, so Pearl's Prussian blue will come positive. So other than these 3 features, liver, pancreas and skin involvement, hemochromatosis can also cause various other presentations. So what are they? In the heart, it can lead to dilated cardiomyopathy more than restrictive cardiomyopathy. This during cardiac system itself we had discussed. So both DCM and RCM can be seen, and in that DCM is going to be much more common. Then it can result in hypogonadism, and one thing here is the hypogonadism is not as a result of deposition of this hemosiderin in the gonads. It is actually because of HPA axis dysfunction. Okay, so HPA axis, hypothalamus pituitary axis is going to be impaired, and here because of that only it is going to present, but not due to deposition of the hemosiderin in the gonads. Remember that. Then the patients can also have joint pain and pseudo-gout kind of presentation. So when the history is given as to there is liver, pancreas, skin involvement, along with that they are giving some history of repeated blood transfusions, or along with that they are giving some heart disease like cardiomyopathy or a hypogonadism along with joint pain, then you'll have to think about hemochromatosis. They'll ask how will you confirm it. So then the correct answer will be Pearl's Prussian blue reaction. Okay, so the most accurate test to detect this hemochromatosis will be serum transference will be elevated. So serum transference saturation will be elevated. So this will be the most accurate test. And how do you treat? You'll have to remove this iron overload, right? So we can chelate this iron with the help of iron chelators like desferrioxamine, or you can do a phlebotomy.